Well, the major class that's considered high efficacy are the monoclonal antibodies. And the first two approved monoclonals, natalizumab and alemtuzumab, had black box warnings and REMS programs, so real risk of progressive multifocal leukoencephalopathy, or PML, that can be fatal, or real risk of autoimmune diseases. And that dampened or limited their broad use in MS. That era changed in March 2017 when we had our first approved anti-CD20, anti-B-cell, B-cell lytic agents. We now have 3 approved, ocrelizumab, ofatumumab, and ublituximab, and no black box warning, no REMS program, so people feel much more comfortable about using them. They are the major high efficacy agents being employed in MS at the current time. There's an ongoing trial that will examine autologous hematopoietic stem cell transplant to see if it's equivalent to the high efficacy agents. And a number of experts, maybe not all, but a number would rate oral cladribine is very, very close to a high efficacy agent. So we really use personalized treatment for MS on the individual basis. And you classically consider the individual with MS and what are their needs and wants, family planning, et cetera. And you talk about the MS state. Do they have highly active MS or very aggressive MS? Do they have poor prognosis, MS or not? Those would really indicate you should seriously think about using a high efficacy agent. And then you're looking at properties of the drug, and you have a special visit to really discuss what might be the optimized disease-modifying therapy. But I think you also need to educate the individual with MS. And there is accumulating data that says the best bang for the buck in using a high efficacy agent is to use it early as the initial therapy in treatment naive individuals. That seems to impact the most on avoiding the development of disability years later. So I think, first of all, you have to have realistic expectations for the patient who's starting a treatment, particularly when they perceive it as high efficacy. So you don't expect, it's never an expectation to improve fixed deficit. You don't expect that symptoms are going to get better, et cetera. It might be very good if you showed improvement, but that's never an expectation. So you really set the stage for understanding this is to minimize future activity. It's almost like invisible therapy to a certain extent. Secondly, you really want the individual to buy into the monitoring program, so you explain exactly what blood tests will be done, how frequently they will be done, how frequently you will be doing scanning of the individual. You want to make sure they understand what is a new neurologic issue that might raise concerns about a breakthrough attack. And I think thirdly, to understand that we're seeing the best approach to treating MS doesn't just focus on choosing the right disease-modifying therapy, but it's a multi-domain process. It's important to try to boost CNS reserve so that individual is going to age better. That means following a wellness program, making healthy lifestyle choices, recognizing that the more comorbid conditions somebody has, the more they are at risk not to do well. So you don't ignore that. You make sure that that gets followed up, even as a neurologist, you may not be the primary one doing it. You don't want to miss high blood pressure, for example. So all of those are key features that the individual initiating treatment with a high efficacy therapy in particular needs to be aware of.